I invite Dr. Neda Rahman for her case.
Good afternoon, everyone. Today I am going to present a case report of iridescent anterior chamber crystals, which is a rare clinical entity found in chronic anterior uveitis. A 34-year-old male presented to the OPD with the following complaints: loss of vision in right eye since 10 years, redness since 1 month, and photophobia since 1 month. History of presenting illness: patient was apparently asymptomatic 10 years back, after which he developed sudden onset loss of vision in right eye, for which he visited local doctor and got treatment. Vision improved for some time, after which it continued to deteriorate. For last month he has complaints of redness, photophobia, and watering. Past history: patient has no history of ocular trauma. He also gave history of episodes of redness and photophobia every 6 to 8 months. Patient has no history of any known chronic medical illness. General examination: patient was conscious, alert, well oriented to time, place, and person. Vitals of the patient were within normal limits. Systemic examination were within normal limits. Ocular examination: on examination, right eye visual acuity was PL negative. IOP 19 millimeters of mercury by applanation tonometry. Eyelid and adnexa were within normal limit. Conjunctiva, circumcorneal congestion was present. In cornea, multiple shiny crystalline deposits over corneal endothelium was present and large KPs were present. Left eye was within normal limits. Right eye anterior chamber, 360-degree posterior synechia was present. Crystalline deposits were present. Flare 1 plus and cells 2 plus were present. Pupil was non-reactive. Lens was cataractous. Left eye was within normal limit. Fundus: right eye media was hazy, and so the rest of optic disc, macula, blood vessels, and peripheral retina was not visualized. Left eye fundus was grossly within normal limits. This is the photo showing the findings of the patient, showing the anterior chamber crystals. Case summary: a 34-year-old male presented with complaints of loss of vision since 10 years, redness and photophobia since 1 month. On ocular examination in right eye, there was circumcorneal congestion, large KPs, multiple shiny crystalline deposits over iris, corneal endothelium, and an anterior chamber. In AC, cells 2 plus, flare 1 plus, 360-degree posterior synechy, non-reactive pupil, and cataractous lens was present. Differential diagnosis: chronic anterior uveitis, cholesterolosis bulbi, phacolytic glaucoma, cystinosis, hypergammaglobulinemia, myotonic dystrophy. Investigations: ESR 45 mm per hour, CRP was non-reactive, Mantoux test serum ACE were within normal limit, RA factor, VDRL, HLA B27 were non-reactive, chest X-ray APV was within normal, PAV was within normal limits, HIV, HbSAg, anti-HCV non-reactive, serum cholesterol within normal limit. Provisional diagnosis of chronic anterior uveitis was made. Patient was started on topical prednisolone eye drops in tapering dose for 1 month and eye ointment atropine for 2 weeks. On 1 month follow-up, redness and photophobia was resolved. Discussion: iris crystals are rare clinical finding in patients with chronic anterior uveitis. They appear as polychromatic crystals, which are seen as refractile deposits over the iris surface and also on the corneal endothelium and the anterior lens capsules. They are thought to be large Russell bodies, which are precipitates of immunoglobulins in the plasma cells. Thank you. These are my references. Thank you.
What is the diagnosis?
Differential diagnosis.
What is the diagnosis ultimately? Crystals. What is the cause of crystals?
Sir, in this case, provisional diagnosis of chronic anterior uveitis was made. Sir,
Mike.
in this case, sir, the diagnosis of provisional diagnosis of chronic anterior uveitis was made.
Was it cystinosis was there?
No, sir.
This iris crystals is quite characteristic. It's often seen in the cystinosis.
I think chronic retinal detachment, very old retinal detachment, I have seen 1 or 2 cases like this, can lead to this. You should have got an ultrasound done at least.
Yes, sir. Patient was lost to follow-up, sir.
Okay.
Yes.
So, and this could be the, did you look for iris neovascularization? Anyways, in any case of uveitis also, you should look for iris neovascularization.
No, sir.
No, there is no mention of iris
No, sir.
neovascularization. So, this may be because of very old RD.
Yes.
Maybe the RD is there for last 10 years, 8 to 10 years.
Yes, sir.
This can lead to this kind of picture. So, an ultrasound was necessary.
Yeah. Whenever you are not able to see the fundus, always do an ultrasound, because sometimes that vitritis is so much that you are not able to see the lesions they are lying behind, because it can be a case of panuveitis which you are dealing with as a anterior uveitis. And as sir said, that in this patient, when you are not able to see the fundus because the patient is having cataract, immediately you will have to do an ultrasound B scan, because in chronic long-standing RD, these type of crystals can be seen, and your patient is PL negative. So at that juncture, you will have to definitely go ahead with that what is lying behind.
And who knows, this is a masquerade, some
Yeah.
tumor is there behind.
This can be a masquerade.
Anyways,
Muscat
thank you.
cystinosis is a good possibility.
Yeah. Thank you.